For 50 years now, the medical world has been throwing its absolute most advanced precision treatments at this one specific, highly fatal form of breast cancer.
Right. And for 50 years, those treatments have essentially just bounced right off.
Yeah, exactly. The survival rates for this subtype simply haven't improved at all. And today, we're doing a deep dive into a groundbreaking 2026 case study that reveals why.
Because we haven't just been using the wrong weapons, um, we've been fighting a cancer that is quite literally wearing a biological disguise.
Which is just wild to think about. So our mission today, and welcome to the deep dive, by the way, we're so glad you're here, is to pull you into the clinical setting to understand exactly how this happens.
Yeah, we are dissecting a fascinating paper published in the Journal of Cancer Prevention and Current Research,
Yeah.
Dabar and his colleagues.
And the central proposition here, it really challenges a half-century of fundamental breast cancer pathology.
It absolutely does. I mean, it suggests that the subtype we currently call classic diffuse invasive lobular carcinoma, or ILC, might be completely misnamed.
Misnamed, misclassified, and because of that, treated with the completely wrong therapeutic approach.
Exactly. And the stakes here, I mean, they really could not be higher.
Right, because this isn't just academic hair splitting.
No, not at all. Despite, billions of dollars poured into oncology and targeted therapies over the decades, this specific diffuse form of cancer still maintains the highest fatality rate among all breast cancer subtypes.
Wow.
Yeah. And this paper offers this profound explanation for that 50-year stagnation. It argues that we have fundamentally misunderstood where this cancer is even born.
So to grasp the flaw in our current diagnostic criteria, we really need to look at the real-world evidence the researchers present. Right?
Yeah, let's look at the actual case.
Right. So the paper centers on a 90-year-old woman who was referred for assessment. She presented with this extensive thickening that occupied basically the entire central portion of her right breast.
And the clinical examination confirmed that thickening, along with nipple areolar retraction and enlarged axillary lymph nodes.
Which obviously right away signals an aggressive invasive process.
Highly aggressive. But the true complexity here, it really reveals itself on the imaging.
Okay, let's unpack this. What did the mammogram show?
Well, the mammogram findings display this totally contradictory combination of features existing in the exact same breast tissue.
Okay.
On one hand, you have multiple distinct circular and oval-shaped tumor masses, like solid, palpable structures.
Right.
But alongside them, occupying that exact same breast, is this massive, non-calcified architectural distortion that completely lacks a central mass.
Okay, so for you listening, an architectural distortion on a mammogram, it doesn't look like a solid lump. It's more like the normal structural lines of the breast tissue are being abnormally pulled or tethered inward toward a central point.
Yeah, almost like a starburst.
Exactly, a starburst, but without a solid core in the middle. Oh, and the researchers also noted extensive bilateral branching calcifications, but
they clarified those were incidental findings.
right, caused by an arterial disease called Munkeberg sclerosis, so completely unrelated to the malignancy itself.
Right, just calcified arteries.
Yeah.
But the central clinical mystery here is the coexistence of those solid circular masses and that sprawling architectural distortion.
Because they look so different.
Completely different. And when we move from the macro level of the mammogram to the micro level of the histopathology, looking at the actual tissue biopsies under the microscope,
Yeah.
that structural contradiction just becomes staggering.
Okay, this is where we really need a logical anchor.
Yeah.
Because if you walk into a forest, right,
No.
and you find a tightly packed, meticulously constructed beaver dam in a stream, and then you look up and see a loosely woven bird's nest in a tree branch.
You don't assume the exact same animal built both of them.
Right, you don't say, oh, the same animal made this brick wall-like structure and this sprawling spider web. The blueprints are fundamentally different.
Yeah, it defies logic.
Yet historically, this umbrella term, invasive lobular carcinoma, it implies these two completely different physical footprints in the breast are the exact same disease.
And the microscope confirms your analogy perfectly. What's fascinating here is that these solid circular masses seen on the imaging are, at the cellular level, dominated by a massive number of contiguous cells.
Meaning they're all touching.
Exactly. They are packed tightly together with almost no intervening connective tissue. It's just a dense, solid block of cells.
Okay.
Pathologists refer to this as the solid form of invasive lobular carcinoma. But the tissue corresponding to the architectural distortion that tethered web-like
It's a
structure.
bird's nest.
Right, the bird's nest. It presents an entirely different cellular arrangement.
That's the diffuse form, right?
Yes. In the diffuse form, the cancer cells are arranged in single files. They aren't packed together at all. Instead, these single-file lines of malignant cells are separated by an excess amount of newly formed fibrous strands. So the disease literally weaves itself through the tissue, migrating outward without ever forming a solid core.
So behaviorally and structurally, these are vastly different biological entities.
Completely. Yet they are diagnosed simultaneously and lumped under the same broad diagnostic label of ILC.
So if these two forms look and behave so differently under a microscope, we have to ask the obvious question, right? Do they actually share the same cellular parentage?
Are they truly the same disease?
Right. And the Tabar paper uses this huge discrepancy to introduce a completely radical origin story. Because traditionally, the assumption in the field has been that all invasive lobular carcinoma originates from lobular epithelial cells.
Right, the cells that line the milk ducts and lobules of the breast. The very word lobular in the diagnosis implies that epithelial origin.
It's baked into the name.
It is. It has been the foundational bedrock of how we categorize and treat the disease for decades.
But the researchers here, they bring in advanced cell culture studies and these deep imaging histopathologic correlations to argue that the classic diffuse form does not originate from epithelial cells at all.
No, it doesn't.
They propose this massive paradigm shift, and they introduce a new terminology, breast cancer of mesenchymal origin, or BCMO.
Yeah, BCMO. They present really compelling evidence that the diffuse form actually originates in the hybrid stem cells of the extralobular mesenchyme.
And the mesenchyme is the connective tissue of the breast, right?
Right.
Entirely distinct from the epithelial lining of the ducts.
Exactly. So we need to unpack how a cell from the connective tissue ends up looking and acting like a cancer of the epithelial lining.
Yeah, how does that happen?
The paper points to a biological process called mesenchymal epithelial transition, or MET. And to really understand MET, we have to talk about cellular plasticity.
Because stem cells are basically shapeshifters.
They are. Stem cells are not locked into a single rigid identity. They have this incredible ability to alter their gene expression to adapt to their environment.
So during MET, these hybrid stem cells from the connective tissue essentially turn certain genes on and off.
Right. They alter their surface proteins and their structural behaviors to basically take on the characteristics of epithelial-like cells.
It's the ultimate biological disguise.
It really is. They change their outward appearance, which allows them to effectively masquerade as epithelial cells as they infiltrate the surrounding tissue.
And that cellular mimicry is exactly why our standard pathology assessments have misidentified them for decades. Pathologists look at the biopsy, they see the epithelial-like characteristics, and they just label it a lobular carcinoma.
Yeah, we have literally been looking at the disguise, completely missing the underlying engine of the disease.
Which is terrifying. And why does that matter so much clinically?
The clinical implications are immense. It all comes down to the fundamental nature of the originating cell. Stem cells are biologically programmed for survival and tissue regeneration.
Right.
When standard chemotherapy is administered, it is designed to target and destroy rapidly dividing cells.
Which is how most typical cancers behave, right? They divide aggressively and uncontrollably.
Exactly. But stem cells, however, are notoriously capable of entering a quiescent state.
Like hibernating.
Yeah, they can essentially lay dormant in the G0 phase of the cell cycle. So when the toxic insult to chemotherapy washes through the body, these stem cells simply weather the storm.
Wow.
They are inherently resistant to standard chemotherapy and radiation therapy because they just aren't actively dividing at the time of treatment.
This makes so much sense. This perfectly explains why the medical community has seen 50 years of stagnant survival rates for this specific disease.
Yeah.
We're hitting it with standard epithelial cancer treatments,
Yeah.
basically poisons designed to kill rapidly dividing cells. But the underlying disease is a stem cell-driven mesenchymal cancer.
That knows exactly how to hunker down and survive the attack.
Yeah. And in the case of our 90-year-old patient, the researchers observed both processes happening simultaneously, right?
Yeah, they did. The hybrid stem cells of the intralobular mesenchyme, so inside the lobule, underwent this transition and created the multifocal solid form.
Okay.
And simultaneously, the extralobular mesenchymal stem cells outside the lobule created the highly lethal, diffusely invasive BCMO.
And when those two forms combine in the same breast,
The overall tumor burden increases tremendously.
which brings us to this critical intersection where clinical testing meets biological reality. If this cancer is successfully executing MET and wearing a disguise, how do our modern diagnostic lab tests handle it?
Well, let's analyze the immunohistochemical or IHC biomarkers from this specific patient, because these are the tests oncologists use to determine the specific molecular profile of a tumor.
Right, that's lab results.
So the biomarker panel for this tumor returned very specific results. It was ER positive, PR negative, and HER2 negative.
Okay.
It was also non-basal, testing negative for markers like CK14, CK56, and EGFR.
Got it.
And crucially, it demonstrated a low level of E-cadherin protein expression and a Ki-67 proliferation index of 24%.
Okay, let's translate that for the listener. What do these markers actually mean for the patient's treatment plan? Let's take ER positive.
Sure.
This means the cancer cells possess estrogen receptors. The tumor is basically using the hormone estrogen as a fuel source to grow.
Right. And in the clinic, this is generally seen as an actionable target. It means oncologists can prescribe hormone therapies like estrogen blockers to effectively starve the tumor.
Okay, and what about that Ki-67 proliferation index?
That is another crucial metric. Ki-67 is a protein that serves as a biological speedometer. It measures how fast the cancer cells are actively dividing.
And hers was 24%.
Right, which indicates moderate proliferation. So on paper, when an oncologist sees an ER-positive, HER2 negative tumor with moderate proliferation, it suggests a disease course that is generally less aggressive, more manageable than, say, a triple-negative breast cancer.
Okay. And another fascinating detail is that low level of E-cadherin, because E-cadherin is a protein that acts like cellular glue, right? It helps cells stick tightly together. So a low level means these cells detach easily from one another, which perfectly explains the structural mechanism behind the diffuse form we talked about earlier.
Exactly. It explains why the cells arrange themselves in those single-file lines, weaving through the tissue like a spider web, rather than forming a solid, sticky lump.
So the molecular data perfectly matches the structural behavior of the disguise.
It does. And based on these IHC biomarkers, the standard medical protocols suggested a fairly favorable prognosis. The Precision Medicine Toolkit indicated this was a treatable epithelial cancer.
But the clinical outcome completely defied the molecular data, didn't it?
Tragically, yes.
Because 5 years and 4 months after diagnosis and the initiation of all that targeted treatment, the patient developed skin metastases on her back.
Yeah.
And the biopsy of those new lesions confirmed they were Gata3 and ER positive, which definitively proved they originated from that primary breast cancer.
Right. And ultimately, she died from disseminating breast cancer of mesenchymal origin 7 years after her initial diagnosis.
So what does this all mean? The patient succumbed to the disease despite receiving treatments aligned perfectly with standard protocols.
Protocols dictated by her biomarker panel.
It's like having a weather app assure you it's a sunny day, while you can literally see a tornado tearing up your front lawn.
That's exactly it. If we connect this to the bigger picture, the molecular data is effectively wearing a blindfold because the cancer has altered its surface proteins through MT.
The lab tests are only reading the disguise.
Right. They are picking up the estrogen receptors of the epithelial uniform without recognizing the resilient stem cell underneath.
So if the lab tests are fundamentally compromised, it seems like the only honest broker left in the room was the original imaging.
Yes, that massive architectural distortion on the mammogram.
The imaging wasn't fooled by the cellular disguise at all.
Not even a little bit. That physical tethering, the massive web of fibrous strands and single-file cells, that was an unfiltered structural read on the disease's highly aggressive, invasive behavior.
It was telling the truth the whole time, while the molecular markers were projecting this false sense of security.
And the authors state this explicitly. While IHC biomarkers have immense prognostic value in true epithelial cancers.
Like acinar adenocarcinoma?
Exactly. Their application in these mesenchymal tumors has a documented, dangerously misleading impact in clinical practice. The vast discrepancy between the predicted, manageable outcome and the observed fatal reality demands a complete reevaluation of how we diagnose this disease.
Which really leads us to the urgent clinical mandate outlined by Tabar and his team.
Yes.
Because with the knowledge that our heavily relied upon lab tests are blinding us to the true threat of this mesenchymal cancer, continuing to group these vastly different diseases under the single outdated umbrella term invasive lobular carcinoma, I mean, it's an absolute failure of precision medicine.
It is the complete antithesis of precise. Grouping them together actively harms patients. The mandate for the medical field right now is to formally adopt the BCMO terminology and acknowledge the mesenchymal stem cell origin of this specific diffuse subtype. Identifying the true biological target is the absolute prerequisite for hitting it.
Because as long as the diagnostic manual categorizes this as an epithelial disease, pharmaceutical companies and researchers will logically continue testing epithelial-targeted drugs on it.
Exactly. We will just keep throwing standard chemotherapy at stem cells that are biologically designed to ignore it entirely.
But changing the terminology changes the entire research trajectory.
It does. Acknowledging it's a stem cell disease allows the scientific community to pivot. We can actually start developing novel therapeutic regimens specifically designed to disrupt stem cell dormancy or target the specific mechanisms of MET.
And it also allows us to reevaluate the cost-benefit ratio of the treatments we subject patients to.
That's a huge point.
Right. Because if we know a specific tumor is a stem cell-derived BCMO, we might spare a patient the immense physical toxicity of a chemotherapy regimen that the biology tells us is highly unlikely to work anyway.
Precisely.
So for you listening, whether you are a medical professional designing clinical trials, an oncologist adjusting your perspective, or just a patient navigating the complexities of cancer care, understanding the true origin of a disease is the foundational step in treating it.
Because treating a symptom or targeting a biological disguise will never cure the underlying pathology. We have to treat the disease for what it actually is rather than what it's pretending to be.
Well said. Let's pull the core elements of this deep dive together.
Sure.
The Tabar case study demonstrates that the highly fatal diffuse cancer the medical world has called classic ILC for decades is actually breast cancer of mesenchymal origin.
All right.
Through a process of cellular plasticity, these connective tissue stem cells adopt an epithelial disguise. And this mimicry effectively fools our standard lab tests, rendering modern biomarker panels dangerously inaccurate for this specific subtype.
Yeah.
And currently, our imaging biomarkers, specifically that architectural distortion visible on a mammogram, provide the most honest, unfiltered warning sign of the disease's lethal potential.
Recognizing this disguise forces a profound reevaluation of how we perceive diagnostic certainty in medicine. And it leaves us with a really necessary provocative question to think about.
What's that?
Well, if one of the most fatal forms of breast cancer in human history has been misclassified and fundamentally misunderstood for over 50 years simply because it changed its cellular uniform,
Oh, wow.
we have to ask ourselves, how many other untreatable, highly aggressive diseases in the human body are currently hiding behind outdated anatomical names?
That's chilling. How many other incurable conditions are simply waiting for us to look past the surface biomarkers and finally recognize their true biological origin?
Yes. Exactly. The illusion of absolute certainty in the pathology lab is comforting, but questioning that certainty is the only way medical science actually advances.
We have to keep questioning the map if we want to find the cure. Thank you so much for stepping into the lab with us today. We will see you on the next Deep Dive.